Welcome back to the Deep Dive, where we take the sources you provide, extract the signal from the noise, and deliver the knowledge you need fast. Today, we are tackling what has arguably been one of the most frustrating puzzles in modern cardiology, treating heart failure with preserved ejection fraction. You'll hear us call it HFpEF. For decades, this condition has been a real clinical dead end. I mean, if you compare it to its cousin, heart failure with reduced ejection fraction, or HFrEF, well, it's a world of difference. For HFrEF, there's a clear, step-by-step playbook of drugs that save lives. For HFpEF, we've basically been stuck just managing symptoms, with almost nothing proven to actually change the course of the disease. We've got a stack of research here that traces this really difficult history, the outright failures, the near misses, and now finally the treatments that are starting to break through. Our mission today is to walk you through that evolution and pinpoint where the evidence finally started to shift.
And that historical context is so crucial. To really get it, you have to understand the clinical staging. We're talking about symptomatic heart failure, that's ACCAA stage C, and our whole strategy is almost entirely based on one number, the left ventricular ejection fraction, or LVEF.
The pumping strain.
Exactly. If that LVEF is low, that's HFrEF, the evidence base is, well, it's rich. You have RAS inhibitors, beta blockers, MRAs, neprilysin inhibitors. It's a proven sequence. But when that function is preserved in HFpEF, the whole disease is different. It's not a weak pump. It's a stiff, non-compliant ventricle. And for that, historically, we had no clear evidence for modifying the disease at all. So the sources we're looking at are vital because they let us separate what, just makes a patient feel better for a bit, like a diuretic, from what truly alters the progression of this really, really challenging condition.
Okay, so let's start where all the disappointment began. Cardiologists finally had these incredible cornerstone drugs that were revolutionizing survival in HFrEF. The obvious next move was just to, export the benefits to the HFpEF population. The thinking was, these are powerful neurohormonal drugs. They target fundamental things like blood pressure and fluid. They have to help, right?
Yeah.
But when you measured them against the real goal-reducing mortality, they just didn't deliver.
That initial strategy was, it was a pretty sobering pattern of failure. The sources detail just exhaustive testing of all these established drug classes, and they were all, it turns out, aimed at the wrong target. These are excellent drugs, but the pathology in HFpEF is just fundamentally different.
Let's get specific. Let's start with the angiotensin receptor blockers, the ARBs. What did the big trials show there?
So we're looking at two main trials. First up is CHARM Preserved, which tested a drug called candesartan. And what's really important here is the nuance. It did show a statistically significant reduction in heart failure hospitalizations. So it was helping manage severe symptoms, keeping people out of the hospital. That's a big clinical win.
Right.
But, crucially, it showed absolutely no difference in all-cause mortality. None. And then you contrast that with the iPreserve trial with a different ARB, irbesartan. That one was even more disappointing. It showed no differences in cardiovascular death or HF hospitalization.
So in one drug class, you get a mixed signal at best. Some hospitalization benefit, but absolutely zero survival benefit.
Exactly.
And failing to move the needle on life expectancy, that's a huge deal for a drug class that was a cornerstone in HFrEF. So why did they still hold out hope for the related ACE inhibitors?
Well, you had to test the whole pathway, The ACE inhibitor perindopril was studied in the PEP-CHF trial, and at first it looked like there was something there.
An early signal.
An early signal, yeah. Some benefits on hospitalizations, even a bit of functional improvement. But the problem was those benefits were, and I'm quoting here, attenuated over longer duration follow-up. They faded away over time. They didn't stick.
So no durable, long-term change?
Yeah.
What about the really old-school drugs, like digoxin? It's been around forever.
The DIG ancillary trial was crystal clear on that one. No impact on all-cause mortality, period.
Yeah.
You did see a modest reduction in heart failure hospitalizations.
There's that pattern again, symptom management.
Always the pattern. Symptom management, but not disease modification. And for beta blockers, another absolute foundation of HFrEF care, subgroup analyses, like from the seniors trial with the Bivalaw, they also failed to show any real mortality reduction in elderly HFpEF patients.
So the story for a decade is basically these drugs are fantastic for a weak, floppy heart HFrEF, but almost useless for a stiff, restrictive heart HFpEF.
That's it in a nutshell. And that realization forced researchers to look in a new direction, to look at fibrosis and stiffness, which leads us right to the mineralocorticoid receptor antagonists, the MRAs.
Spironolactone.
Spironolactone. These are potent antifibrotic agents. On paper, they seem like they were tailor-made for the stiff HFpEF heart.
Which brings us to the TOP-PTAT trial. This is probably the messiest, most controversial trial result in the history of this field. These antifibrotic drugs were supposed to be the home run, but the results were just confusing. Can you unpack that for us?
Oh, it was a mess.
Yeah.
So TOP-PTAT tested spironolactone, and the headline result, the overall result, was that it showed no improvement in the primary endpoint. That was a composite of CV death, HF hospitalization, or aborted cardiac arrest. So a failure.
But it's never that simple, is it?
Never. Because buried in that failure, there was a signal of benefit for hospitalizations. But here's where the real controversy starts. A post hoc analysis, so an analysis after the trial was done, found these profound regional differences. The patients who were randomized in Russia and the Republic of Georgia, they had totally different baseline characteristics and really low adherence compared to patients in the Americas.
I see.
And the sources are clear that the apparent reductions in death and hospitalization were seen specifically in that Americas subgroup. So this immediately raised the concern that the overall negative result was, quote, obscured by major issues in other regions.
Wow. So that puts a doctor in an impossible spot. You have this huge, expensive trial that fails globally, but a really clean signal from one well-controlled part of it suggests the drug actually works. How did that mess translate into clinical guidelines?
It leads to what we call a weak recommendation. The guidelines do sort of suggest using spironolactone, but it's really based on the strength of that America's data, balanced against the fact that the overall trial was neutral. And you have to stress the downsides. MRAs have real risks: hyperkalemia, high potassium, and worsening kidney function. You have to monitor patients very carefully.
And as if that wasn't complicated enough, there's another study, ALDO-DHF. It confirmed the drug was doing something good. It improved how the heart looked on an echocardiogram. It was fixing the stiffness on paper.
Right. It improved diastolic dysfunction indices.
But it completely failed to improve exercise capacity, symptoms, or quality of life.
Yeah.
So you're left with a drug that makes the echo look better, but doesn't make the patient feel or function any better.
And that is the core frustration of HFpEF. It really pushed researchers to just abandon the old drug classes and explore a completely novel idea, a new paradigm.
Right.
And this new paradigm focused on the theory that systemic microvascular endothelial inflammation was the real driver of the myocardial stiffening, and that it worked through impaired nitric oxide or NO signaling.
That theory sounds really elegant. You fix the NO deficiency, relax the blood vessels, decrease stiffness, and the heart can relax better. So how did the actual drugs targeting NO do in testing?
Another deep disappointment. The theory was logical, but the clinical trials were a catastrophe. First, they tried sildenafil, a PDE5 inhibitor that enhances NO activity. Some small early trials were promising.
Of course.
But the big one, the phase 2 RELAY-X trial, failed completely. Patients on sildenafil showed zero improvement in functional capacity, quality of life, anything compared to placebo.
Wait, so if the whole working theory was microvascular inflammation and NO deficiency, and then you have drugs targeting that pathway that fail,
Right.
Does that just kill the whole theory, or did they just pick the wrong drugs?
It forced a massive reconsideration. It suggested the pathology is way more complicated than just boosting NO bioavailability. And look at the other NO drugs. They tested nitrates, which are direct NO donors, in the NEAT-HFpEF study. Not only did this fail to improve QOL or exercise capacity, the sources emphasized that the patients actually experienced a decrease in their overall activity levels.
They actually made patients worse in terms of their daily function. That is a huge step backward.
It is, and the same thing happened with inorganic nitrite in the INDI-HFpEF study. Also failed to improve functional capacity. The evidence was just undeniable. The NO targeting drugs were not the answer.
Okay, so we've got a clear history of failure. Old HFrEF drugs don't work. MRAs are a confusing mess, and the shiny new NO pathway was a disaster. This is where the story finally pivots, with two totally different drug classes: neprilysin inhibition, the ARNIs, and the SGLT2 inhibitors. Let's start with the ARNI, sacubitril/valsartan, and the Paragon-HF trial.
Paragon-HF was a massive moment because it finally broke that therapeutic drought. But the trial itself gave us what we call a near miss.
A near miss.
The study showed a clear directional 13% reduction in the primary endpoint, which was CV death and total HF hospitalizations. That's a clinically relevant number, but it narrowly missed statistical significance. The p-value was 0.06.
Oh, that's painful.
Yeah.
For anyone who doesn't follow this, 0.05 is the magic line in the sand, so it was officially a negative trial, but just by a hair.
Excruciatingly close.
So how does a near miss like that turn into a landmark approval?
It was all in the subgroup analyses. Researchers saw these strong, consistent benefits in other important things like quality of life and kidney function. But crucially, the sources highlight that the biggest benefits were really concentrated in specific groups:
And who were they?
women and patients who were on the lower end of the preserved EF spectrum, what we now often call the mid-range EF group.
That's fascinating. Why do you think it works so much better in women in that mid-range group?
That is the big question. Some theories suggest that women in the trial maybe had a slightly different underlying pathology, something closer to the type where an ARNI is most effective. And for the mid-range EF patients, well, their disease likely shares more in common with HFrEF than true high EF, HFpEF, so they're just more responsive to this kind of drug.
And based on all that data, sacubitril/valsartan got approved in the U.S. for symptomatic heart failure across the full spectrum of ejection fraction. The first drug in a long, long time to get that approval, a huge turning point.
Absolutely. It showed that targeted therapy was actually possible, but the real game changer came from a totally unexpected place: the SGLT2 inhibitors.
The diabetes drugs.
Exactly. This class of drugs, sodium glucose cotransporter 2 inhibitors, was made for type 2 diabetes, but turned out to be phenomenal at reducing heart failure, even in people without diabetes. We already saw it crush it in HFrEF with the DIPA-HS study.
And these drugs seem to work on completely different pathways, metabolic and inflammatory ones, totally sidestepping the old failures we just talked about. So what's the latest on extending that benefit to HFpEF?
This is the most exciting area in cardiology right now. Because they work independently of that classic RAAS axis, they offered this fresh hope. And we now have the results from 2 massive trials, DELIVER with dapagliflozin and EMPEROR preserved with empagliflozin. And these trials have now conclusively demonstrated that SGLT2 inhibitors reduce cardiovascular death and heart failure hospitalizations in HFpEF patients. This confirms that this class is the true breakthrough the field was waiting for.
That's incredible. Finally, a second proven tool in the toolbox. But even as these new therapies roll out, we have to remember the foundation of management is still the clinical basics. Let's just quickly review those essential strategies.
Yes. The new drugs are fantastic, but the core principles still focus on aggressive management of congestion and all the comorbidities. First, diagnostic caution is critical. HFpEF isn't one disease, it's a syndrome. So you have to rule out specific conditions like cardiac amyloidosis, hypertrophic cardiomyopathy, or pericardial disease. These are different diseases and require totally different specialized management.
And once you've confirmed it's true HFpEF, what's the #1 priority for symptom management?
Aggressive fluid management. Decongestion. You have to get the excess fluid off with diuretics. That's what causes the suffering and the hospitalizations. But it's a very delicate balance.
Why is that?
Because if you take off too much fluid, decrease the preload too much, that stiff ventricle can become underfilled. And that leads to low blood pressure, worsening kidney function, azotemia, and even fainting. It requires really precise, careful work. And beyond fluid, it's aggressive control of blood pressure and managing atrial fibrillation, which is just devastating in HFpEF. Maintaining a normal rhythm, or at least controlling the heart rate, is essential. And finally, lifestyle. Exercise training improves functional capacity and quality of life. It's non-negotiable.
I thought the note in the sources about chronotropic insufficiency was interesting, this idea of a mechanical fix for exercise intolerance.
It is an interesting hypothesis. The idea is that some patients don't tolerate exercise because their heart rate doesn't increase enough. And theoretically, you could fix that with a rate-responsive pacemaker. But as the sources clearly state, this is still an unproven idea. It's not guideline recommended right now.
So if we just step back and look at the whole journey, we've moved from a total reliance on managing secondary things, blood pressure, AFib, diet, through this long, dark age of failed trials, to now the emergence of targeted therapies like ARNIs and the SGLT2 inhibitors.